Hello and welcome to Week 5, Healthcare in America, HSM 110. This week we're going to talk about quality, access, and cost. When we think about cost, access, and quality, those are basically the major cornerstones of the healthcare delivery model. There's an interactive relationship between the three, between the cost of what people have to pay for healthcare, their ability to get care when needed, and the quality of services delivered. The premise is basically that your ability to access care is directly influenced by the cost that you have to put out to gain healthcare. Cost and access are the big concerns in the United States. A recent survey, and I can't remember what organization did it, found that most health system CEOs rated access as their biggest concern for the future of their health systems. Quality is also taking center stage in a lot of this. It aligns very well because quality reflects the type of product that we're offering to our patients. Cost is definitely a factor in quality. It's that you'll get what you pay for mentality. And quality is achieved only when accessible services are provided. You can't say you have a quality organization if no one can get in, if you're cherry picking the type of patients you get in. You have to have a quality organization for all types of patients who you treat in your organization. As the Affordable Care Act was being developed about 11, 12 years ago, Dr. Don Berwick, who was a pediatrician and professor at Harvard and a great healthcare thinker, who later went on to become the head of CMS, the Center for Medicare and Medicaid Services, in the early Obama administration, he developed this concept through the Institute of Health called the triple aim, which basically balanced quality, access, and cost. For the operational purposes, quality is defined as improving the individual experience of care. So there's a lot of things that go into that. Access is improving the overall health of populations. And cost is reducing the per capita cost of care in those populations. So let's break those down and look at them individually. Quality is all about raising the bar on outcomes. It's a process of constant reflection and improvement, meaning that you have to be very honest with yourself and you have to continually look at yourself and ask yourself what you can do better. It requires organizations to be very deliberate and, as I said, honest in their self-assessments. You can't cherry pick data. You have to look at data, the good, the bad, the ugly, and everything in between. It has to also be built on rigorous standardized systems of measurement across a wide variety of operating metrics. And by that we mean that the systems, you can't measure one thing one way and then the next time you look at it, measure it a different way. You have to be consistent in how you're measuring things, and you have to have a system of rigor or organization and standardization and process in place as you look at those. And you have to look at them across a wide variety of metrics. You can't just look at one metric like length of stay and say you're doing well. You have to look at mortality rates, you have to look at infection rates, you have to look at patient satisfaction, all kinds of different metrics when you're evaluating quality. And it's not just looking at them, you have to measure them. You have to measure them against not only themselves, but against yourself. You have to be willing to look at yourself over time. You also have to measure yourself against the industry. You can never get better if you're only looking at yourself. You have to look across the wider marketplace and the wider industry. You need to be comparing yourself to the whole market, and you need to really be striving to be the best. And the only way you can know you're the best is if you can put yourself up in consistent, rigorously applied metrics that you've measured over time. That's why organizations have what they call scorecards or dashboards that talk about strategic performance measures. We're going to get into that in a lot more detail down the road here because it's a very important tool that hospitals use in their operating systems, that health systems use as part of their operating systems. So why does quality measurement matter? It shows you the performance of the organization over time. You can tell how you did, how those performance improvement projects have done for you. Is it making a difference? Is it making it worse? Is it making it better? It also allows you to see what you're doing relative to what your overall strategic improvement plans and goals are. Every year you go through a process where you're evaluating where you do strategic planning, where you're evaluating your market growth, your market position, your care delivery models, how you do things. In that process, you develop a set of goals which are defined by metrics or measures to tell you how you're doing in advancing toward those goals. If you're not consistently and ongoingly measuring what's going on, you don't have a sense of how you're doing throughout the year, and you can't make course adjustments. So it's really important to be measuring things consistently and reporting it back over time. There's a thing called Pearson's Law, which basically sums up that which is measured improves, and that which is measured and reported on improves at a faster rate. So you have to be looking at this stuff and reporting it out. It gives you comparisons to similar organizations, so you can know how you're doing compared to your competitors. You can know how you're doing across a broader continuum. And it also gives you that direction you need for that planning that I talked about. At the end of the year, when you look at what went right and what went wrong when you're in your planning cycle, you can say, you know what, we need to improve here, and this needs to be a focus for next year. So the only way you're going to know that is if you're doing good, solid quality measurement. When we hear access, we often think that it's about getting an appointment to see a physician, getting into the doctor's office, or getting into the hospital. It's really more than that. That's a big component of it, but it's really more than that. Access is really it's about improving the health of populations. And it's not just about the availability of care. When we talk about improving the health of populations, we look at things like disparity in the delivery of care. Are there urgent care clinics in the area in comparison to other areas? What are the factors that create the lack of care or lack of providers in a certain area? It's a big issue in rural health. It's a big issue in inner city health. You see a lot of, especially in the rural areas, you only see small numbers of primary care physicians and next to no specialists. That's an access issue. It's also a population health issue for those areas. The other thing that access focuses on is beyond the availability is also the experience of care. First of all, how quick are you able to get in? You should be able to get into a primary care physician office pretty fast. It shouldn't take more than a day or two to get an appointment with a primary care physician. If you have a cold and you need to get into your doctor, you want to get in right away. You don't want to wait 2 weeks because that cold is going to resolve itself, or that infection is going to resolve itself. Now, a specialist like a surgeon or an oncologist or a neurosurgeon, you're going to wait a little longer because that's the issue you have might be a little more chronic, and you're willing to wait for that specialization. But at the primary level, you're going to want to get in you're going to want to get in a lot faster. When we think about access and how we measured it, there's an organization called the Institute of Medicine, and they put together a really nice model that shows 6 key measures of care that really speak to the experience of care. Is it safe? Is it effective? Is it timely, patient-centered, equitable, and efficient? These are very broad measures, and they have specific measures underneath. So each of these categories comes with its own specific measures. Is it safe? What are the infection rates? What are the comorbidities? What are the risks involved in providing the care? Is it effective? What's the cure rate? How are they doing it? What's their length of stay? What's the readmission rate? Is it timely? This is that access thing. Can you get in fast? Is care delivered quickly? Patient-centered. Is it built around the needs of the individual patient, or is it built around the needs of the physician or the health system? Equitable, and equity. Is it consistent across an area? Do all members of the population have the same or similar access? This is where market justice and social justice kind of intersect a little bit. Market justice, to be effective, has to recognize that social justice component and how to balance the social justice component with its market-based bent. And then efficiency and effectiveness are very similar, but efficient just talks about, are you doing things as well as you possibly can? These are all big, important access measures. They also relate to quality, so you can see the connection between these. I was once at a conference about 8 years ago, and Press Ganey is an organization that does patient satisfaction monitoring for health systems. Their model is built off the HCAHPS model, and it's approved for use like an HCAHPS model, which is what the federal government requires. Don't ask me what HCAHPS stands for. Google it. I can't remember. But a person was speaking at this meeting, said something that struck me, and I wrote it down, and I keep it in my phone because I think this is a really key important point about patient engagement and patient satisfaction in particular. This woman said, patients don't give us permission to do them harm. And that struck me because patients come to us, they're in a vulnerable position. They usually don't feel well. They usually have an illness, accident, or injury. Now, even in a preventive medicine visit, they feel fine. They don't want to feel worse. So they're not giving us permission to make them worse. They're giving us permission to help them and make them better. It's a really important point for health administrators to remember, because we have to do everything we can to make sure that we're not harming them, be it making them wait too long. I mean, it can, giving them the wrong medication or actually physically hurting them, or harming them in a different way, making them wait too long, not explaining bills, creating, confusion or anxiety and angst. Those are harms, and you don't want to do that as a healthcare administrator. So I mentioned equity a little bit, but the general definition of health equity is where everyone has the opportunity to be as healthy as possible. This doesn't mean that everybody gets the exact same thing, and this is where market justice and social justice intersect, as I mentioned. And where they really disconnect is the concept of health disparities. And these are differences in health outcomes and their causes amongst groups of different types of people. So if you use ethnicity or race as an example here, African American children are more likely to die from asthma compared to non-Hispanic white children. That's a disparity. That means that in those communities that are predominantly African American, something is going on that care and the recognition of asthma is not being seen and handled in the same way as in non-Hispanic white communities. It's a problem, and it's something that has to be affected. I don't know the data around this statement, but it's just one of those things that sets up the need for the social justice component to come in. And there's a market justice element to this too. When you think about, there's an economic concept of externalities. And what that is in economics, if you take econ, you'll learn this. Externalities are, you want the external environment to look good around you because that raises the overall value of the situation. I own a home. I live in the suburbs. I own a home. I mow my lawn. I take care of my yard. My bushes are trimmed. Everything looks good. I keep my house in nice shape. I want the guy and the man and the woman on either side of me, I want them to do the same thing for their house. And the reason I want that is because if their house looks nice and my house looks nice and our neighborhood looks nice, the value of all of our property is going to rise. Those are positive externalities. If my neighbor doesn't mow his lawn and throws old furniture out in the yard, that makes my house look worse because by association with this guy. When you take that and apply it to health disparities, are our communities truly healthy if we have pockets that aren't receiving the care that they need, same type of care? If one area is getting better care than another area. And that can be driven by socioeconomic factors, it can be driven by race, it can be driven by ethnicity, it can be driven by a lot of things. It can be driven by geography, just the fact that it's harder to get to an area, so you don't want to put a hospital there, or population density, things like that. So the point here is that the more we reduce health disparities, the more we influence the positive externalities of our communities and the greater value we bring for everybody. So the final leg of the three-legged stool of the triple aim is cost. Now, what does cost mean? Well, it's really kind of how you look at it. When you think of cost, you automatically think of price. What is that physician's bill or the premium you're paying on your health insurance? So what does it cost me? That is the price. What do I have to put out in exchange for the service I'm going to receive? The next is healthcare expenditure, or no, I'm sorry, I said that wrong. The price being, what am I charging for the service that I'm offering? The healthcare expenditure or spending is what am I going to put out for what I'm receiving? And that's basically the formula of price times quantity equals expenditure. So if I buy one Diet Coke for $1, and I need 6 Diet Cokes, it's going to cost me $6. So price times quantity equals the amount I'm going to put out. It's the same with healthcare. If I need to see 5 doctors, that's whatever the price is times whatever their price is times 5 equals what I'm going to end up putting out. It reflects the consumption of economic resources and how care, when we're having care delivered. A lot of things included in this, things like health insurance, professional skills. So the difference between a nurse practitioner, a primary care physician, a specialist, or a specialty surgeon. The drugs we take, the medical equipment we have to use, new kinds of drug discovery, things like that. There's all kinds of things that factor into health expenditure. And then the resources required to deliver care. And these are the cost of doing business type of resources. And you need to make your costs back. If you don't make your costs back, you're not making any money and you're not able to continue to provide that service. The income equation is very simply stated. Income equals revenue minus expenses. Well, the revenue is a function of the price in the healthcare. The function of the price, the healthcare expenditures are spending, those are the expenses, and then the resources. So you can see how this all ties together. The resources required to deliver care, they include things like staff salaries. That physician has nurses. That physician has someone at the front desk greeting you. That physician also pays rent. That physician probably has some nice equipment in their office that they had to put out some capital for. And there's Band-Aids and gauze pads and all kinds of other stuff in there. That stuff's not free, so you have to factor that in when you're looking at the overall cost. So that's a very high-level, quick overview of cost, access, and quality and how they fit. The book does a nice job going through these, and I highly encourage you to look through it. But if you walk away from nothing else, remember that cost, access, and quality are the triple aim. Regardless of what you think of the Affordable Care Act, this concept of triple aim helped create a strategic roadmap for health administrators in the healthcare community to really strive toward and work toward as they move forward in putting together services for the communities. So remember, quality or improving the individual experiences of care, access, improving the health of populations, and cost, reducing the overall per capita cost of care for populations. So in closing, I want to remind you to read the chapter or chapters if you're behind. It's very important. This is a really good textbook, and I really encourage you to read it. Also, any of the supplemental materials I'm putting them out there for a reason. I want you to look at them. I want you to know them. They're going to help you down the road, especially the videos. If I post videos, I want to make sure you're looking at those. There's some tutorials coming in future weeks, and I want to make sure you're paying attention to those. And be sure to turn in all your assignments on time. That's always a key thing. So with that, I will sign off. If you have any questions, you know how to get me, either email or a phone. And I look forward to continuing to move forward as we go through healthcare in America.